So today's lecture is on pericardial disease. We're going to look at acute pericarditis, you know, how to make the diagnosis, what are the echo features of acute pericarditis. It looks like pericardial effusion because, a lot of time when you have acute pericarditis, you do have some pericardial effusion, and you have to distinguish between pericardial and pleural effusion. Cardiac tamponade, because if you have pericardial effusion, you have to determine is this cardiac tamponade, yes or no. So those are questions you have to answer. And then constrictive pericardial disease, you're going to see a few cases. It's a very prominent topic when it comes on to any type of exams, any type of tests. And they usually want you to distinguish constrictive pericardial disease or constrictive pericarditis from restrictive cardiomyopathy. So on all exams, you'll get this. So it's something that you should try and understand and note the difference between these two entities. All right, so let's all right, we're gonna move on to acute pericarditis. So when we talk about itis, any type of itis, it's an inflammation, and acute pericarditis is just acute inflammation of the pericardium. And usually these patients are in a lot of pain. Okay, and we talk about a pleuritic pain, so it's like a sharp stabbing pain, usually increase with activity, deep breathing, stuff like that. But the thing about acute pericarditis, that pain is relieved if the patient sit up and lean forward. So if you get any question with the patient sitting up and leaning forward and the pain is reduced somewhat, it's acute pericarditis. But so those are the symptoms that the patient will present with. What are the more common cause of acute pericarditis? Idiopathic, which means we don't know what caused it. The patient does have the typical chest pain and the EKG or the ECG features, but we don't know the cause. And then in infection, so infection is a big cause for acute pericarditis. Renal failure. So you'll find patients who are, talk about uremic, patients in probably acute renal failure, even chronic renal failure. From time to time, these patients can develop acute pericarditis. Myocardial infarction, patients who have a heart attack, because remember, a heart attack is when the heart muscle dies and the heart muscle is in contact with the pericardium. So if you have inflammation involved in the myocardium, that can extend to the pericardium. And we talk about Dressler syndrome, probably a couple of days after the acute myocardial infarction, acute heart attack, patients will present with acute pericarditis. And it's very important in that setting because you have to make sure it's not an extension of the heart attack, and so you don't start treating the patient for an extension of the heart attack, because the treatment for pericarditis is completely different. Mm-hmm. All right. So other causes of acute pericarditis, malignancy, okay, cancer. So if you have cancer, in close proximity to the if you have cancer in close proximity to the pericardium, you can get inflammation of the pericardium, pericarditis. Radiation, patients who have tumors in the chest, and if they get radiation, they can develop acute pericarditis. Trauma, penetrating and non-penetrating trauma can give rise to acute pericarditis. Collagen vascular disease, very common cause. Lupus and rheumatoid arthritis, two examples. Medications that can do it, procainamide and hydralazine. Okay, procainamide is an antiarrhythmic medicine. Hydralazine we use to treat hypertension. So those can cause it. So the first, again, with acute pericarditis, the patient is going to present with the typical chest pain, so sharp stabbing chest pain, usually aggravated when the patient lies flat, relieved somewhat when the patient sits up and leans forward. When you look at your 12-lead ECG or EKG, you have widespread ST segment elevations. That is ST segment elevation in all the leads, and PR segment depression. And this is your parasternal long axis view. This is a diastolic frame because the mitral valve is open and the aortic valve is closed. So this is the septum, your LV cavity, your posterior wall, and this is your serous pericardium. Your parietal pericardium is right there, and this darkened area is fluid. This is fluid. This is what we call pericardial effusion. Okay, it's a fluid in the pericardial sac. This is the descending aorta. Okay, your mitral valve. This is the anterior leaflet and the posterior leaflet of the mitral valve. This is the left atrium. Okay, your aortic valve closed right there. This is the aortic root and the ascending aorta, right ventricular cavity. Whenever the fluid tracks anterior to the descending aorta, it is pericardial effusion. If the fluid tracks posterior, that is behind the descending aorta, then it's pleural effusion. Okay? So this fluid right here is pericardial because it's tracking anterior. It's going to go anterior to the descending aorta. Okay? All right. So that's acute pericarditis, and we do see a number of cases, and you have to make the diagnosis. So we spoke about pericardial effusion because a lot of these conditions are going to present with pericardial effusion. All right. So the causes for pericardial effusion is pretty much the same as for acute pericarditis. Okay. So the causes for pericardial effusion, idiopathic, patient have it, there's no viral infection, whatever, we just don't know, idiopathic. Infectious, patient may have some type of lung infection, or, whatever, or they may have an endocarditis, something and the other. Metabolic, we talk about renal failure, hypothyroidism. Hypothyroidism is a fairly significant cause of pericardial effusion. Renal failure, especially if the patient has, say, end-stage renal disease and they're on dialysis, say hemodialysis, and the hemodialysis is not complete, then these, one of the things that these patients will develop is pericardial effusion. So one way to manage the pericardial effusion is to adequately dialyze the patient. Okay, malignancy cancers we had mentioned before. Radiation to the chest, the patient may have a tumor, may have some type of Hodgkin's or non-Hodgkin's lymphoma and radiation. Or they may have a lung cancer. Trauma, as mentioned, collagen vascular disease, SLE, rheumatoid, medication. So you have to remember the medications: procainamide, antiarrhythmic, hydralazine for high blood pressure, minoxidil for high blood pressure as well. All right. Signs and symptoms of pericardial effusion. Those of you who do echoes know that a lot of the patient comes in and you don't know that they have pericardial effusion. So a patient may be completely asymptomatic. They come to the echo lab for, something else, and you find that they have some effusion. Signs and symptoms: low voltage ECG, because if you have fluid around the heart, the voltage of the ECG tends to be low. So that's one of the tip-off. Okay. Again, we said the patient may be completely asymptomatic. The ECG may show evidence of acute pericarditis, and as we said, the hallmark of acute pericarditis is sinus tachycardia, diffuse ST segment elevation, and you get what we call PR segment depression. So you're going to have ST segment elevation in all the leads except AVR. In AVR, you're going to have ST depression. Okay, so again, the hallmark features of ECG features of acute pericarditis: sinus tachycardia, diffuse ST segment elevation, PR segment depression. All right, and if the patient has a large amount of pericardial effusion, you get something we call electrical alternance, which is you have when you look at the voltage on the ECG, they're varying from beat to beat. So one is going to be high, the next one is low, the next one is high, the next one is low. That's what we call electrical alternance. So sometimes that may be a tip-off that a patient may be in tamponade too. Because if you have someone comes in syncopal, low blood pressure, and you see electrical alternance, you listen to the chest and you can't hear the heart sounds, then you have to put everything together. All right. So again, tamponade is big. You have to, when patient comes to the lab with pericardial effusion, your job is to say, well, I'm not going to let this patient out of the lab if they have tamponade. So you have to prove to yourself that they don't have tamponade, because tamponade can kill the patient. All right. So clinically, patients in tamponade will be hypotensive. When you listen to the heart, because of the fluid, the heart sounds are going to be distant. They're not going to be crisp and as loud as you would hear it if there is no fluid. They're going to have elevated neck veins, elevated JVP, shortness of breath, and then syncope, because they cannot increase the cardiac output because of fluid around the heart. All right, so one of the best views to look for pericardial effusion is a subcostal view. So subcostal view, and if you see the fluid all around the heart, we talk about a generalized pericardial effusion. So, those of you who do the echoes, this is subcostal view. This darkened area is the pericardial fluid, okay, and it's all around, okay. So you can have a loculated pericardial effusion where it's just located in one area, and not because it's loculated, the patient can still have tamponade. So you have to bear that in mind. So you go through the echo evidence for tamponade, okay? You talk about the definition for tamponade is diastolic collapse of the RV or RA, and you can see that on two-dimensional echo. You probably can see better on your M-mode echo. All right, and then we look at the mitral inflow, and if you have more than 25% decrease in your E wave with inspiration, that is also very diagnostic. All right, so parasternal long axis, you can measure your effusion, or you should measure your effusion, and when we are localizing the pericardial effusion, you can just say which chamber it is adjacent to. So this would be adjacent to the posterior wall of the left ventricle. If it was here, this would be left atrium. If it was there, then it would be your right atrium. So you just use the cardiac chamber to identify the location. Okay. Again, if the fluid that you're seeing, if it tracks anterior to the descending aorta, then it's pericardial. If the fluid tracks posterior to the descending aorta, then it's pleural, and it's important. So again, this is your M-mode echo. You have your two-dimensional echo on top, your M-mode echo on the bottom. You always have to do this because it's very evident when you do your M-mode echo. So you can see the structures. The cursor is located here. It passes through the chest wall. It passes through the portion of the pericardium, the pericardial fluid, the RV wall, the RV cavity, the wall of the aorta, the aortic valve, the left atrium. So these are the structures that the cursor passes. Okay, and these are the same structures you're going to get in your M mode. So the first thing you encounter is the chest wall. Okay, the pericardium. This is the parietal pericardium is right up here. Okay, this is your pericardial fluid. Okay, so the darkened area is the pericardial fluid, and just below that you'd have the serous pericardium, and then the RV wall. So this is the RV wall. So you know the RV wall have indentation periodically. There are indentation in the RV wall. Then this is the RV cavity. This is the RV cavity right there. This is the aortic wall. Okay, and inside the aortic wall you have the aorta. The aorta is inside the aortic wall. Below that you have the left atrium. The same structures that you're seeing right there, that's what is depicted below on your M mode. Okay, so the M mode is only going to see the structures that the cursor passes. But if you remember the definition for tamponade, it is diastolic collapse of the RV, right ventricle. Diastolic collapse. We are seeing that there are collapse in the RV wall periodically. But is this diastolic collapse? Or is it systolic collapse? Or it is just collapse whenever? There's an ECG on top. So, you can use the ECG. If the ECG is not helpful because, for whatever reason, the artifacts, it's not, it's not on properly, then you have to come up with other means of determining if this collapse is diastolic collapse. Okay? But, you can do that because below here, you have the aorta with the aortic valve inside. And the aortic valve only opens in systole. There's no other way. The aortic valve opens in systole, closing diastole, opens in systole, closing diastole, opens in systole, closing diastole. So if you follow the collapse is only when the aortic valve is closed. These collapse is only when the aortic valve is closed. So it is diastolic collapse. So this is evidence of cardiac tamponade, M-mode evidence of tamponade, because the collapse is occurring during diastole. Remember, the aortic valve opens in systole, so it closes in diastole. Aortic valve closes in diastole. All right. So tamponade. The definition for tamponade is diastolic collapse of the right atrium and the right ventricle. Okay? When you look at the IVC will be dilated, and you're not going to get your collapse of the IVC with inspiration. Remember that you're supposed to get more than 50% collapse of the IVC with inspiration. With tamponade, the IVC is dilated, and you're not going to get your inspiratory collapse. And Also extremely important is septal bounce or abnormal septal motion. So please look for it. Okay? Septal bounce, abnormal septal motion. All right? So what happens in inspiration? You get an increase in blood flow in the right side of the heart. So when you take a deep breath in, what usually happens, there's a compression. You get compression of the blood vessels in the abdominal cavity, and in the chest, because you take a deep breath in, there's an increased negative pressure. So the blood vessels in the chest opens. So blood rushes from the abdominal cavity into the chest, and you get increased blood flow into the right side of the heart. So, that's a normal phenomenon. But when you have a large amount of fluid in the pericardial sac, the RV cannot dilate to accommodate this increased blood volume. Okay? The RV cannot increase its size to accommodate the increased blood flow. So what happened? The septum bulges to the left. So in inspiration, when you have increased blood flow into the RV, the septum bulges to the left to accommodate the increased blood flow into the RV. And then in expiration, when you have increased blood flow into the LV, the septum moves to the right so that the LV can accommodate this increased blood flow. So the septum is going to be moving back and forth, and that's what we call a septal bounce. Okay? Abnormal ventricular septal motion. In inspiration, it's going to move to the left, and in expiration, it's going to move to the right. If you see this, it's almost diagnostic. All right? So again, see some fluid right there. You just put your cursor across it and you can look. And if you see something like this, then you have diastolic collapse, okay, which is diagnostic of tamponade. All right. Again, we said that the IVC, the inferior vena cava. So the inferior vena cava drains into the right atrium. This is your hepatic vein. So the IVC is going to be dilated, reflecting the increased pressure. So the IVC is going to be dilated, and you're going to have a lack of inspiratory collapse in the IVC. And then, very important, when you do your Doppler across the mitral inflow, you put it down. Remember, you're going to decrease the sweep speed. The normal sweep speed is about 50 millimeters per second. You're going to decrease your sweep speed to about 25 millimeters per second. And normally you'll have a respirometer. Okay? With inspiration, you're going to get a decrease. So if you get decrease in your E wave with inspiration by more than 25%, then that's also very suggestive. Okay? So more than 25% decrease in your E wave with inspiration, your mitral inflow. All right. So you have to know how to diagnose tamponade, because, patient comes to the echo lab and they have fluid. Your job is to make sure they don't walk out of the lab with tamponade. Okay. So we just went over how to diagnose tamponade. Now, constrictive pericarditis, the importance of that, you're going to see a few cases, yes, but on all your tests, they love this, and they love it because constrictive pericarditis and restrictive cardiomyopathy, their presentation is usually very similar. And they love for you to distinguish the two because the treatment is different. The treatment is completely different. With constrictive pericarditis, you have a thickened calcified fibrotic pericardium that forms a non-compliant shell around the heart. So it's like the heart is encased in this stony covering, because that's what it is. It's a calcified fibrotic pericardium, which is like stone. So the heart is just, when in diastole, the heart is bouncing against this thing because it cannot expand. So it's bouncing against this thing. The systolic function is good, but the diastolic function, it cannot accommodate a significant amount of blood in diastole. Okay, it's a non-compliant shell around the heart. So it prevents the heart from expanding when blood enters. Again, the causes for constrictive pericarditis, TB is a big one, tuberculosis. So in former years when TB was common, we used to see much more constrictive pericarditis. Fungal disease, fungal infection, parasitic infection. You can get it from inflammatory and autoimmune processes, chronic pericarditis, post-viral pericarditis. A big cause now is post-surgical. So once you have to do any type of surgical procedures on the heart, you can get pericardial effusion, and if there's blood mixed with that, then it can become fibrotic and calcified. You can get constrictive pericarditis. Also post myocardial infarction with so-called Dressler's syndrome. All right. Post-radiation therapy as well, chronic renal failure, connective tissue disorder, SLE, rheumatoid, cancer, neoplasm. So similar to pericardial effusion, because pericardial effusion or pericarditis can eventually give rise to constrictive pericarditis. Okay, so what are some of the signs and symptoms? Heart failure, because if the heart cannot expand to fill with blood, the patient gonna present with heart failure. Okay, so that is why it's very similar to your patient with restrictive cardiomyopathy, because when you look at them, the patients are going to be in heart failure. And if you just look at the echoes, the ejection fraction may be normal. Okay? The ejection fraction may be normal. So you can't just look at that and say one is constrictive pericarditis and the other is restrictive cardiomyopathy. They both will present with heart failure. Both will present with ascites, that's fluid in the abdominal cavity, hepatomegaly, enlarged liver, and peripheral edema. The legs are swollen. Okay, so both set of patients are going to present with these features. Kussmaul sign, that is a raised JVP with inspiration. Remember what we said? In inspiration, you have increased blood flow into the right side of the heart, but because the right side of the heart cannot really accommodate any more blood, because we said the septum going to have to shift to the left. So the blood is going to back up into the atrium and back up into the superior vena cava and into the jugular vein. So with inspiration, you're going to get an increase in the JVP, that's the jugular venous pressure. When you look at the jugular vein, when the patient takes a deep breath, it gets prominent, very prominent. So very astute clinicians, will observe this and can make some assessment. So that's called the Kussmaul sign, raised JVP with inspiration. And then pericardial knock, that's because when the heart expands in diastole, it has nowhere to go. So it's knocking on the pericardium. And remember, the pericardium is a stony shell. So whenever the heart expands, it's knocking in this stony shell and gives you a diastolic sound we call pericardial knock. It's a diastolic sound because the heart is expanding in diastole. Patients going to be fatigued, which is in keeping with a heart failure. And they may also have pleural effusion as well. So how do you make the diagnosis of constrictive pericarditis? I'm going to go through a series of things, and then I'm just going to give you 3 things that you need to remember. Okay? So, of course, you want to look at your M mode. Okay? You want to look to see if there's pericardial thickening. With constrictive pericarditis, a lot of time you'll also get some effusion. You'll also get some pericardial effusion. Okay? So, and then when you do your 2-dimensional echo, you get your thickened pericardium. But the pericardium may be normal in 20% of cases. So if you're looking for thickened pericardium, you may miss the diagnosis in 20% of patients. This is key though, abnormal septal bounce. If they have constrictive pericarditis, they're gonna have the abnormal septal bounce. So in inspiration, the septum is going to move to the left because it increased blood flow into the right ventricle. In expiration, the septum is going to move to the right because you have increased blood flow into the LV. And if you get flattening of the posterior wall during diastole, and again, a respiratory variation, ventricular size, the RV is larger in inspiration, smaller in expiration. Dilated IVC, dilated inferior vena cava, lack of inspiratory collapse. Okay? All right, so this is the posterior wall flattening. You see that in M mode, so you look at the posterior wall flattening. All right, so this is, so M mode you can also the septal, you can see the septal bounce on M mode as well. So with inspiration, it's going to move to the left, and then with expiration, it's going to move to the right. Okay, so we can see that. Okay, so a lot of these patients going to have some amount of pericardial effusion. They'll have a small amount of pericardial effusion. You can see that. All right, so looking on stuff, looking for pericardial thickening, looking for effusion, looking for septal bounce. Sometimes, if you don't have very good vision or you're not accustomed to looking at these things, you may miss it. Okay? All right. So we have pulse wave Doppler and tissue Doppler that we can use to help us to make the assessment. So remember, constrictive pericarditis is a pericardial disease. It's not a muscle disease. So you're not going to have evidence of muscle damage. Okay? All right? So when you look at your mitral, all right, so one of the things with the patient's in heart failure. The patient is in heart failure. So one of the things we know about heart failure, for you to be in heart failure, your filling pressures, your left ventricular end diastolic pressure is going to be elevated. And one of the things that we can use in Doppler to assess LV filling pressure is what we call the EE prime ratio. Okay? The EE prime ratio. If that is more than 15, and we're talking about the medial annulus, the medial mitral annulus, if the EE prime ratio is greater than 15, it suggests elevated filling pressures. So it's not telling you that it's constrictive pericarditis, it's just telling that the patient is in heart failure, and to help you to assessment. The thing that is crucial though is your E prime, because it is not a muscle disease, so your E prime is usually very large, more than 7 centimeters per second, indicating no myocardial disease, no muscle disease. Constrictive pericarditis is a pericardial disease, it's not a heart muscle disease. Heart muscle disease, your E prime is usually less than 7 centimeters per second. As a matter of fact, we talk about annular paradoxus, where the medial E prime is usually very, very large. But anyway, so what's going to happen? The patient is going to come with heart failure. You do your EE prime ratio more than 15, suggestive of elevated filling pressures. You look at your mitral E, it's going to decrease its inspiration by more than 25%. Okay, but you can also get that with COPD. We talk about, that's one of the features. You can also get this with tamponade. So it's not going to distinguish constrictive pericarditis. It's going to help you a little bit. Mitral E decrease with inspiration more than 25%. All right. Elevated EE prime ratio. The thing that is crucial is your E prime velocity, which is more than 7 centimeters per second, telling you that you're not dealing with a muscle disease. So, you have to think now constrictive pericarditis. All right. So, again, if you look at this, this is looking at the mitral inflow, and you're just looking at decrease in your E velocity by more than 25% with inspiration. Okay, so that's what this is showing. So this is what respirometer. Okay, so inspiration, you're going to get a decrease in the E. Okay, and then with expiration, it gets big. So it has to be more than 25%. So how you do that is your expiration E minus your inspiration E divided by your your expiration E. Your septal bounces is different. It's different because it's a respiratory thing. Your septal bounce is different from paradoxical septum because it's a respiratory thing. Okay, with inspiration, it's going to move to the left. With expiration, it's going to move to the right. It's different. So never call it paradoxical septum. Paradoxical septum is the septum is going to per beat. The septum is going to move in a paradoxical fashion per beat. All right. Again, because it's not a muscle disease, when you do your tissue Doppler, the medial mitral annulus, you're going to get an exaggerated E prime. Okay, exaggerated E prime. If it was a muscle disease, your E prime would be very small. Okay, all right. Again, the IVC is going to be dilated, and you're going to get a lack of inspiratory collapse. Dilated, lack of inspiratory collapse. And you should always do your M mode to look on it because you can see it much better when you do the M mode. You can see if there's inspiratory collapse, yes or no. The other thing that you need to know, which is almost pathognomonic, is when you look at your hepatic vein flow. Hepatic vein flow. With expiration, you get an exaggerated atrial reversal. Hepatic vein flow. With expiration, you get an exaggerated atrial reversal. Okay? Remember, your normal hepatic vein flow, okay? Your normal hepatic vein flow, you guys should be on top of this. You're supposed to know this fully. Your normal hepatic vein flow, all right, let's draw it. So, all right, so this is your hepatic vein right here, and your transducer is right here. Your probe is right up here. Blood is flowing from the hepatic vein into the inferior vena cava. It's moving away from the transducer. So in systole, because it's moving away, it's going to be below the baseline. And then in diastole, it's still moving away, so it's going to be below the baseline. But when the atrium contracts, it's going to push blood back into the IVC and push blood back into the hepatic vein, and it's going to go towards the transducer. That is why your atrial reversal is on top. Atrial reversal is on top. So this is your systolic component. This is your diastolic component. And your atrial reversal. Okay? This is the normal hepatic vein flow. Systolic, diastolic, atrial reversal. What we're saying in patient with constrictive pericarditis, when you do your hepatic vein flow, with expiration now, you see with inspiration it's low, but with expiration, the atrial flow reversal is going to be huge. So the three things that you need, the three things that's going to give you almost 100% surety that it's constrictive pericarditis. You look at, of course, the patient presenting with heart failure and all that sort of good stuff. Well, septal bounce is very important. Septal bounce is very important. Okay, so with inspiration, the septum moves to the left. With expiration, it moves to the right. Okay. When you look at your tissue Doppler imaging, the patient is in heart failure and you think it might be a muscle disease, your E prime is going to be large. A large E prime, so you have to now think constrictive pericarditis. When you look at your IVC, it's dilated and you have a lack of inspiratory collapse. Okay, and then when you do your hepatic vein flow, and if you get an exaggerated atrial reversal with expiration, this is almost 100%. Okay, so constrictive pericarditis, it comes in all exams. If you can make the assessment clinically, then you're good. But more important, you have to get it right in the exam. Okay. All right. So that's constrictive pericarditis. Let's just go back. All right, so I think we're going to stop here. Okay, so this lecture is very important because we see pericardial disease every day in the echo lab, and it's very important for you to make a good assessment of what's going on.